I'm Tracy Macaulay-File. I'm here at the Williams Cancer Institute. It is September 7th, 2021. I'm here for breast cancer. This is my second occurrence. The first occurrence was in 2018 in Canada. I was diagnosed with ER/PR positive, HER2 negative breast cancer in the left breast. It was 8 centimeters and I had it surgically removed. I thought after having it surgically removed that I would no longer be dealing with cancer, but unfortunately I have a reoccurrence. I sought out the Williams Cancer Institute for alternative care. I've been seeking alternative care because of not wanting to do chemo or radiation. Based on statistics and information that I've read, I've really wanted to seek out a different kind of therapy, hoping for a longer cancer-free result. The Williams Institute has been really gracious, and I'm impressed with the ability to get it done as quickly as I have been, because with cancer you're kind of a ticking time bomb and you're hoping to get things done as quickly as possible. Cancer is such a difficult diagnosis. It comes with so much stress. So I'm here today to see if I can relieve some of that stress by ablating the tumors and giving my body the immune response that it needs to not create more cancer.
I'm certainly glad that you were able to come here, and we really appreciate that you trusted us in your care. And certainly, this procedure, it's an amazing procedure. I think you probably know, my grandmother had breast cancer when I was young and watched her go through mastectomy, radiation, chemotherapy, and being, young and impressionable at that time, I thought there's got to be a better way. And when I started doing, research in college and seeing that how we treated animals and injecting things into them, this makes a lot more sense. And then, in the early 2000s, getting into a lot of ablation and doing breast ablation and quickly doing breast cryoablation. And it's amazing how slow it's been that this is, not the standard of care, but I do think we're getting momentum. I think we're going to start seeing it more soon. There's been, at least some clinical trials, but obviously, people want to see thousands, tens of thousands of patients, and that's going to take a while.
How many patients do you think you've seen?
I've probably, across the board in ablations, probably 6,000-7,000 patients. Yeah. So
you would have good information just from what you've done.
Yeah. So we have, of course, one of the things, we have a lot of advanced patients. So the first few years when we were doing breast cryoablation, one of the things was that you couldn't really do it for, you could, but early stage patients wasn't quite acceptable. So what we did was the advanced patients who still had their breast lesion, but then it already spread and nobody wanted to operate on them. So they were considered stage 4. And or the other was patients who, for whatever reason couldn't tolerate anesthesia or other problems. So we did a lot of those, and those patients, actually one of the longest that we had was a stage 4 patient that we did cryoablation of the breast, and she had widespread metastatic disease. She didn't want to do chemo or anything else, and she lived 11 years with us only treating the breast.
Wow.
Yeah. So that's, one of those.
Stage 4 is
right.
kind of a death.
Well,
sentence, right?
Normally without treatment, because she did it like no treatment at all. Normally a patient, would live maybe a couple years at best.
Right.
And yeah, she did quite well just with, ablation, kind of holding things in check, and that was seeing a lot of patients like that. And those were kind of the early years, and then we started getting more and more, feeling comfortable seeing that those patients did well. They didn't get, recurrence in the breast or anything else. And then we started advancing into the early stage patients, which I was doing those, before most people. There were a few people doing a little bit, but and then now, of course, we have, these, Frost and other clinical trials that have been done that, further supporting this. But those are the official clinical trials. The results that we have, they have value, but they really have value to support the clinical trials. It's hard to publish some of this data because they'll look and say, well, that's not random and that wasn't done in certain ways. But we are in the process on our own to try to help support other clinical trials, and so hopefully soon we'll see a lot more of this.
How has cryoablation evolved since you first started?
So the systems, particularly initially, most of the systems were based on argon gas and helium. So it used a argon gas that went through a small needle, and basically the principles when the gas travels through a narrow channel, it actually drops the temperature and causes freezing. And the helium is actually used to heat it back up. It circulates through. With the small needles, you had to place a lot of them to be able to get a bigger area. Then when the newer system like the iSense came out, we've had an iSense since 2014. So now going on 7 years, and that's a liquid nitrogen. And so one of the things that we know from work from Dr. Michael Sable from University of Michigan was that he looked at the freezing rate, and if the freezing rate was faster, then the chance of recurrence, the chance of metastasis seemed to be less. Liquid nitrogen freezes much faster, freezes much colder, and so and also you only need one needle because it has a big ice ball, whereas the others are tiny, so you have to kind of stack them all together. And the problem with that, and this system, actually the argon systems are probably a cryoablation done in the world and also in the United States is probably 99%. Now not as much breast because the newer systems that are just designed for breast are leaning towards the liquid nitrogen. But faster, bigger ice balls, and if you can freeze a bigger area with a single needle placement instead of imagine having to stack a bunch of spheres to cover the area, well, you have a bigger chance of missing that. And in those other needles, you always had to use at least 2 needles. You couldn't freeze even hardly a centimeter with one. So you couldn't do a larger tumor at that time. But you could, but you had to use a lot of needles and a lot of stacking. Right. And so that was part of the problem. Certain areas. That's right. Yeah. So now you can cover what bigger areas. Well, so there's the size of what we could freeze and the size of what you should freeze because, I have done tumors 16 centimeters before. It's again even stacking with these bigger needles. However, that's in certain situations when that was really years back. Now we don't do as much of those. We would probably inject it with something to try to shrink it down to get it more manageable and then freeze it. Because some of these bigger tumors, when you freeze them, you're probably killing too much tumor volume at once, and that flooding of the pieces of dead tumor may actually suppress the immune response. So would you get something like tumorlysis? Is that? It's not as much tumorlysis, but you get suppression of the immune response because the immune system is seeing too much dead tumor. Right, and so it thinks this can't be something I should attack. This must be an injury. And it'll actually start to protect the tumor more. So you have to be careful. There's kind of ways that you do it, sizes that you would do. It depends on the case. Like if you're doing, a localized cancer such as yours, then you're trying to freeze everything. If you're doing a patient who's advanced, then you actually might not want to freeze everything. One of the things that we've learned is that in advanced disease, the piece of tumor that you leave behind, so say you freeze 70 or 80%, the small percentage that you leave behind actually starts to make immune stimulating substances that cause the tumor to get attacked. This was very surprising. So it really red flags the tumor for the immune system to go in, and then it does, but the tumor itself is actually making this. So that's why you leave a little bit behind. You wouldn't do that in local disease because that would be, it's just like with surgery. That's a localized disease, but advanced disease you would consider leaving some behind and doing it in a certain way. What you would also want to do it, with immunotherapies and other agents like that. But the thing that we've been exploring more recently is the concern, everybody's concerned about spreading of tumor from surgery. I mean, I always talk about surgery, but biopsy is actually probably the bigger culprit. And so we've started this technique where we because when you stick the cryoablation needle into tumors, not as traumatic as a biopsy. The biopsy is, the needle's popping in there, it's cutting through tumor. Whereas, the cryoablation needle, you can kind of get smoothly into the tumor without disrupting much, and you can freeze. And so you freeze, and then you biopsy the tumor after you froze it. So then your whatever you have there would be dead, and what we've been able to show is that we can biopsy it, and the pathologist can still read it.
Right.
Where, that was the main concern. Could we still tell what it was after we froze it? We figured you could, and so far, we've tested it and done that, and that seems to work. And so now we need a study with that, where the patient, instead of getting biopsy, then other treatments, they should be ablation biopsy.
Okay, so if a person was stage 1,
early stage, that's what they should
say immediately do.
That's what I did. Yeah. That's when I treated my wife. That's what I did.
Okay.
I froze hers and then I biopsied it.
Okay.
So and that's.
And it doesn't affect the biopsy at all, or
it doesn't seem to. The pathologists have been fine with doing everything, receptors and all. So no real issues there. Yeah, that was then certainly the concern, but I think it's much safer. And there's been questions before. John Wayne Cancer Institute, which is in Orange County, California. They were the ones that probably did the most known study of how much does a biopsy spread a tumor. Well, you need a biopsy because you need to know what what it is. Is it cancer? Is it not? You need to know receptors. You need to be able to do other genetic testing. So not doing a biopsy is not a great option, but how can you do the biopsy in the most safe way? And I think that freezing it is the safest way.
Okay. So I'm ER/PR positive and HER2 negative. Do you think that for cryoablation it makes any difference in what the pathology of the tumor is? Not
so much from the actual local disease. So just like surgery, the risk, obviously like triple negative breast cancer tends to be more aggressive. Of course, you can look at things like Oncotype DX to also look at what the potential for recurrence is, but ablation kills tumor regardless of receptor status. Now we do know from an immune side of things, some of the actually like triple negatives may be more immunogenic than hormone positive cancers, surprisingly, but. So they may be more aggressive from the overall standpoint, but they may respond better to immunotherapy. So yeah.
So for me personally, I'm a reoccurrence.
Right.
There was 3. You think there was 3? So
I think there was the one main nodule, and then along the scar site looked like 2 smaller nodular areas.
Okay.
So. And the one thing is that what we're seeing in cryoablation across the board, whether you do immunotherapy or you don't, is that there may be some component of an immune stimulation.
Right.
And the clinical trials, though we need a lot more patients, are certainly looking like the percentage of recurrence and metastasis should be lower with cryoablation. Though we can't definitively say that, but we've suspected this for a long time, and I think that in the future we'll see that. Or such as a case like yours, or what we pretty much do with all of our ablations now is inject at least obviously injecting something like ketorolac or a COX-2 inhibitor. That's without question. We do that in everybody. But injecting other immune stimulating agents and like. You have natural agents like PB10, rose bingle. There's a few others as well too. EBC46, which comes from the blushwood berry. So there's several options on that you can inject locally to boost that immune response without having the potential risk of like autoimmune issues and things like that with that more heavy hitting immunotherapy that you would reserve for advanced cancer patients.
Okay. So you were talking about the PV10. That is derived from
roses.
Flowers.
Roses, yeah.
Right.
Yeah. So originally called rose bingle.
Okay.
There's a company that's developed it, but of course there's the formulations that you can get because it is actually FDA approved.
Right.
Just not for this purpose.
Okay.
So it's available and can be available even in the U.S. I mean, you can use it there.
Right.
So I think that should be, and again, it would be nice to have a clinical trial so that you could look and say, okay, what happens when you do cryoablation alone, cryoablation with, NSAIDs such as ketorolac or COX-2 inhibitor, or combination with, rose bingle PV10.
So the mechanism of the ketorolac is to prevent inflammation.
So it inhibits prostaglandins that are actually involved in this inflammatory, but it's almost like a healing response that happens, and that can stimulate the cancer growth. And so all the NSAIDs actually boost the immune response to the cancer. So, for example, patients getting systemic immunotherapy, if they take aspirin or other NSAIDs, they get an enhanced immune response by reducing what we call prostaglandin PGE2. So, and that's obviously it's inexpensive. I don't know. There's obviously there's a few other doctors starting to get into cryoablation now, and I'm not sure that they're doing this, but they should.
Right.
I mean, anybody that when I talk with doctors and talk about the process of doing ablation, we always say, you should at least inject an NSAID into the location.
And I think that's what made you unique. When I was seeking out someone to do cryoablation, you were the only one that I could find that was, adding that component to it. Because of having surgery the first time, when they didn't use anything like Cataract or anything for the inflammation. Right. And I was grossly inflamed at the time, which I think is possibly why the surgery didn't take the first time.
Sure.
But when I did some research, I found that you were the only person doing that component.
Yeah, we've been doing that for quite a while. I mean, I would say that in ablations, at least 10 years.
10 years you've been doing that? As standard of your care?
It's standard, yeah. So, we kind of, there were various things that we've, had that kind of phase in and out of the years. One was using low-dose cyclophosphamide, which is, it's considered a chemotherapy agent, but at low dose it actually suppresses the regulatory cells, and it's a pill. You can take it by mouth. That can enhance the immune response from cryoablation. But there was previous studies with the NSAIDs, and kind of adopted that early on into ablation, and then later it's been sort of more and more shown, particularly in, I think it was initially breast cancer surgeries, where they were finding that if they gave ketorolac to the patients at the time of surgery, their risk of the cancer coming back or spreading was significantly reduced. Right. So it's like, it makes no sense. I mean, there's a lot of things like that make no sense. I mean, I think 1992 there was studies with selenium showing it decreased breast cancer risk by 50%, and yet nobody really talks about. I mean, that should almost be like something
standard
you teach in school,
right?
And say, hey, they teach young women to do self breast exams. I mean, they should also mention things like that.
Right.
So, but hopefully those things will change.
So for me personally, my percentage, like we always talk about in the Canadian system, we talk about what percentage of potential does it have for coming back from. In my case, I know that's like asking me to look at your crystal ball, but
so it's difficult. I mean, when you look at it and you have a patient who has recurrence, local recurrence, you kind of say, well, their percentage chance of it coming back is probably a little higher than a first treated patient, which, we would sort of say like an early stage breast cancer, cryoablation, what's the risk of it coming back? Well, roughly like 8%. Now in the studies that were done, it looked like it was 1%, but that's well, that's a real restricted study too. So it's giving you really the best of the best. I think if you kind of spread it out a little more, it's going to be higher than that. But I think it's going to be very comparable to lumpectomy, and probably a little better than lumpectomy. And so I'd say, you know, in your case, probably a little bit higher, but still, but not a lot.
Okay.
You know,
well, because of the immune component
Right.
as well, because
Right.
now it's triggered my immune system.
Exactly.
Okay.
Yeah. So, yeah. So hopefully you won't ever have to come see us again.
Yeah. Not that I mind. It's been great,
well, we appreciate
but-
you visiting.
Yeah.
But the social visit will be
Yeah.
fine. So,
Yeah, no, I
Well.
appreciate you doing this. So aftercare, how can I make sure that?
So you know that's an important point, because actually a lot of there, you know, there's a few doctors that are doing cryoablation in the U.S. and a lot of their patients are coming to me for their aftercare, because they're like, well, the doctor's not telling them what to do. They're doing a lot of ablations, and I'm not sure, maybe, you know, I don't know if they're just not feeling comfortable with it. But you know, typically one thing is that, you know, the breast swells a little bit. You feel you know, a little sore. We recommend, you know, not really doing significant exercise, certainly for at least 1 week. I mean, you can start like walking and doing lighter exercise after a week. I'd probably wait a few weeks before doing like any, you know, particular you know, exercise in the gym or things like that. But for the most part, you're not going to hurt anything. You're just you might have pain yourself. The big thing on follow-up is, you know, how do you follow to monitor the cancer itself? And there's a few different ways, and different depending on early stage breast cancer patients. You know, typically we do, you know, MRIs. We do at some point we do PET CT scans. You know, like your case being a little bit different, being a recurrence, we're going to throw in a little more PET scans than we might do on a typical first treated early stage patient. There's the standard of care would be actually just, you know, doing mammograms on those patients, but I don't fully trust those enough. In some patients you can do those, but typically you're going to need, you know, an MRI to follow, and in certain cases PET CT. There is for some patients, but for the most part, a lot of the early stage cases, there's some blood testing, like the cell-free tumor DNA. A little difficult for you guys in Canada. In the US, it's a little easier to do. But yeah, those and you know, we'll want to follow the patients usually every 6 months for the first 2 years. Then after that, if things are looking good, we'll start spacing it out. If we have any concerns, we might even change. If we're concerned of anything, we might even step it up. You know, we could do things every 3 months if we need to.
So would my doctor be able to recognize on the scans what that looks like, or is that something that you?
That's why all of our
at?
Patients, we have to see the imaging.
Right.
So we can't really. I mean, obviously we look at the report and see what they say, but we have to look at it. You know, I have to look at it for myself, and that's the advantage of being a radiologist and doing the procedures, because, you know, radiologists, that's what we're trained in doing, not only reading the scans but doing these under image guidance. I mean, we're the ones that usually do a lot of the ultrasound guided biopsies and all the other procedures. For the surgeons, this is a newer technique for them, and so a lot of the ones that are, well, some of the doctors that are starting to get into it are the surgeons. I'm sure in time they'll learn and get very good with it, and the radiologists will become more comfortable reading post-ablation scan. I mean, I'm already seeing on some of our patients reports where the radiologist is like, oh yeah, this patient had ablation, looks good. And that's you know, becoming more common, so, which is a good thing.
It's a good thing,
yes.
Because I can see from Canada that they probably won't be able to understand what they're necessarily looking at, right?
Might not, but you know, it just depends. I mean, yeah, sometimes they look at it like, oh my gosh, I don't know what's going on here, and they sort of just you know, just say something about it. Usually they don't want to say anything. They want to say, well, could be good, could be bad, I don't know, and leave it at that. And then we have to, of course, look and make our own decision with it. So. But yeah, you are seeing, I think, more and more, particularly your more dedicated breast imagers are becoming comfortable looking at ablations now. So,
Great.
Yeah. Well, very good. Well, thank you.
Thank you. It's been a good experience,
Well,
actually.
good. I'm glad.
Yes, I. How long ago did I actually have it done? 3-4
Yeah,
hours
it's
ago.
been a few hours.
And here we are talking.
Exactly.
Yeah,
Yes. Yeah.
impressive.
That's the one thing that there are a lot of the doctors that do it under local anesthesia, which is fine. It's okay, but I find the patients are a little bit uncomfortable when you do it just under local. I think giving the patient, some anesthesia is much better.
Right, and you probably want us not to move.
Not to move and to be, comfortable and not extremely, that you're going to be anxious, but at least the least that you can be. So we've found in the past that, when you do this, the other thing is that, it takes a little time to do it. This is not, I think some of the companies that sell the systems, they want to say, well, this is like a 30-minute procedure. Well, yeah, you could do it in 30 minutes, but that's pushing it. I mean, you don't need to rush this. You got to do it right and methodical and make sure you're getting the good coverage of the area. So
it's ultrasound
guided. Yeah. So we have, like, in your case, we had your PET CT. If we'd had some issues identifying it under ultrasound, but we match it with your PET CT, and we could have done CT to match with your PET, but we try not to, because CT is not the best imaging for breast anyway. Okay. And so we can see everything with ultrasound. And so almost 100% of these are done with ultrasound.
Okay. So if somebody wants to see you, the process would be to contact the Williams Cancer Institute and proceed from there and
if they contact our office, and usually we have some some information to fill out, kind of see if they're a candidate. We request imaging and records, and the real key is always the imaging. I'm hesitant to turn anybody away without actually seeing their scans. Even their reports. A lot of times the patients say, well, let me just send a report. But what if the report's wrong? Right. And I might turn a patient away that we could treat. And that certainly, I mean, I look at, but sometimes I'll look at the report and say, oh, no, this is not going to be a candidate for us. Then when I see the scan, I'm like, oh, yeah, no, this is actually better than I thought. Sometimes the reports are a little deceptive, and as they say, a picture's worth 1,000 words, so we need to be able to see it.
Right.
So, All right, well, very good. Well, thank you for talking with me.